Good evening, ladies and gentlemen. On behalf of CCP, I warmly welcome you to the Cutting Edge Lecture Series with international faculty. The Ceylon College of Physicians has initiated this program as an innovative peer learning platform to share knowledge and learn through experience with international faculty. This month, Ceylon College of Physicians is collaborating with Sri Lanka Society of Nephrology. We are grateful to them for their active contribution. To introduce our distinguished speaker, I cordially invite Prof. Arosha Disanayaka, the President of CCP. Over to you, sir.
A warm welcome to all the participants this evening. On behalf of the Ceylon College of Physicians, I'm the President, I'm Arosha Disanayaka. This is the second in our series of cutting-edge lectures. Now, the thinking behind this, we have a three-pronged peer learning program for the CCP for 2022. We have peer learning from international experts. This is called the Cutting Edge series. In addition to that, we have peer learning from our colleagues who serve in distant hospitals, in the smaller hospitals in Sri Lanka. That's called the Peripheries of the Four. As well as we have a peer learning process from our very senior colleagues, the past presidents, etc. And that's called Pearls of Wisdom. So this is a three-pronged learning process. And then we are here in the month of March. Month of March is the nephrology month of March. And then we have cutting edge lecture in nephrology for March. And it's a great honor for me to welcome such a distinguished speaker this evening in Sri Lanka and afternoon in the UK, Professor Wheeler. A very warm welcome to you from Sri Lanka. It's such a pleasure to have you, and I'm deeply honored that you're taking time off your very busy schedule to be with us. And I just need to thank Dr. Waziel, who has been instrumental in setting up this lecture. And then to carry on the formal introduction of Professor Wheeler, may I invite Dr. Waziel, and then of course Dr. Waziel, once the introduction is over, Professor Wheeler will speak to us on the lecture, followed by questions from you, which can be directed on the webinar chat box, which will be answered by Professor. So much. Over to you, Dr. Waziel. Thank you.
Thank you, Arosha. A warm welcome to all of you for today's webinar. It is on a very timely topic, recent advances in diabetic kidney disease. To deliver the webinar lecture, we have a distinguished resource person in Professor David Wheeler. Professor David Wheeler is professor in renal medicine at University College London, UK, and honorary consultant nephrologist at Royal Free Hospital, London. He is a clinical scientist interested in complications of chronic kidney disease, especially those that increase the burden of cardiovascular disease and accelerate progression of kidney failure. David has participated in the development and running of several large-scale clinical trial testing lipid-lowering regimes, calcium mimetics, and SGLT2 receptor inhibitors in patients with chronic kidney disease. David has been involved in the development of clinical practice guidelines for several organizations. More recently, for kidney disease improving global outcome, KDIGO. He has served as KDIGO co-chair between 2012 and 2019. He is past president of the UK Renal Association and past chair of UK Renal Registry. There are many Sri Lankan nephrologists who are fortunate enough to work trained under him and under his mentorship, and I am also one of them. And with that, it's my pleasure to invite David to deliver his talk.
Dr. Waziel, thank you very much for that kind introduction. It's wonderful to see you again, and a privilege and an honor to be asked to speak at this symposium. I hope I've now shared my slides and you can see my first slide. So as you heard, I'm a nephrologist. I work in North London. I work in the management of chronic kidney disease, and I have done or become involved in a number of clinical trials over the last few years. I'm going to show you the results from some of these trials, but I want to put these trials in the context of the disease that we're treating. So here's the patient that I look after. He's a 73-year-old male with type 2 diabetes. He's had his type 2 diabetes for over 20 years. And unfortunately, he's developed end-stage kidney disease as a result of diabetic nephropathy. He attends our hemodialysis clinic 3 times a week. He's also got retinopathy and unfortunately is registered blind. He's also got cardiovascular disease with a previous ST segment, non-ST segment myocardial infarction, which has left him with a low ejection fraction. He's had a recent transient ischemic attack, and we're now worried about his legs. He's already had a left midfoot amputation, and he comes to dialysis in a wheelchair. So this patient really is in a bad state now. And I would argue that what we want to try to do is prevent patients getting into this position of ending up on hemodialysis as a result of diabetic kidney disease. So why don't we look further back, and why don't we look at the prevention of this problem and the prevention of the development of chronic kidney disease? So what we need to do is to pick up these patients at a much earlier stage. And what I'm showing you in this graph is the time course of diabetic kidney disease. You'll see in the blue line, the GFR. You'll see in the red line, the ACR, or the urinary albumin to creatinine ratio. And you'll see that in the early stages of diabetic nephropathy, after around about 10 years of diabetes, there may actually be an increase in GFR as a result of hyperfiltration, and then the gradual onset of albuminuria. Albuminuria increases over time. EGFR then starts to fall away and drops down to 0. And as GFR drops, so does the albuminuria drop, because when you haven't got enough functioning nephrons, your albuminuria will diminish. So this is a 20-year course from the onset of diabetes to end-stage kidney disease. And the patient I've just shown you is right here at the end of this course. He has end-stage kidney disease. He's on dialysis. He's lost vast majority of his kidney function. What we want to do is pick this patient up much earlier. We want to pick him up in the early stages of disease. We want to manage his kidney disease, and we want to slow the deterioration of his kidney function. And I hope that I will convince you that we can now do a lot to slow the progression of diabetic kidney disease, but we need to pick patients up early. So if you look here, why don't we pick this man up when his EGFR is still high, at the point that he starts to develop albuminuria. This will give us the maximum opportunity to treat his kidney disease and slow down his kidney failure. Now, of course, to diagnose kidney disease, we need a blood test. And as we're all aware, that blood test is sent off the laboratory. A blood creatinine is measured. Certainly in our laboratories, this creatinine is put into a formula that requires the patient's gender and their age. And from that formula, we get an estimated GFR or EGFR, which is approximately a percentage kidney function. So here on this patient, the EGFR is 36.7, normal greater than 60 or greater than 90, depending on whether you're looking at CKD or normal kidney function. So here we've got a patient who has an EGFR of 36. Right. What else do we need to make a diagnosis of chronic kidney disease? Well, we need a urine test. And we need a urine test because for the patient I've just shown you, we're only going to pick up early chronic kidney disease by assessing the amount of albumin that's leaking in the urine. And in the UK now, we collect any urine that the patient can produce for us. It doesn't have to be a timed collection. Any urine sample the patient can give us. We send this off to the lab. We measure the ratio of albumin to creatinine. So we get the albumin to creatinine ratio, and this allows us to stratify or to further stratify patients' risk, as I'll show you in just a minute. So we get the albumin to creatinine ratio. Now, by definition, chronic kidney disease is 2 EGFR measurements below 60, and they have to be at least 3 months or longer apart. And if the EGFR is normal, or we can use the albuminuria to establish the diagnosis of chronic kidney disease. So if we have a UACR of greater than 3, and I'll talk about the units in a minute, and it is persistently greater than 3 over at least 3 months, we can make the diagnosis of chronic kidney disease on the basis of the ACR, even when the EGFR measurement is above 60. I'm going to say that again in just a minute, but let me just make the point that we have a classification system now that allows us to classify the patient by their level of GFR and by their level of albuminuria, the albumin to creatinine ratio in the urine. So we have here GFR from 90 down to 15, and we have 6 stages of chronic kidney disease based on this EGFR. And we have across the top of the rows here the level of albumin in the urine as the albumin to creatinine ratio based on that spot urine sample. Now, we use in the UK milligram of albumin per millimole of creatinine. In the US, the units are milligram per gram, and those units are approximately 10 times greater. So it doesn't matter what units you use. The important thing is to classify the patients according to their level of albuminuria. Now, if your patient has a GFR of greater than 60 and does not have albuminuria, they probably don't have chronic kidney disease, and they're in the green boxes on the grid here. If your patient has an EGFR of greater than 60 but does have albuminuria, then they have chronic kidney disease. And if your patient has a GFR which is persistently below 60, then they also have chronic kidney disease regardless of the level of albuminuria. So the only patients on this grid who do not have chronic kidney disease are those who have GFRs above 60 who don't have albuminuria. All the rest of the patients in these different categories have chronic kidney disease. And you'll see here we can categorize the risk by both the level of EGFR and by the level of albuminuria. So green is low risk, yellow, orange, and red are higher risk, progressively higher risk. If you look at the G stage 3, that's EGFRs between 45 and 60, the level of risk increases across the different albuminuria strata. So going from low risk if the patient has no albuminuria to high risk if the patient has a 3 range of albuminuria. So we're using both the EGFR and the level of albuminuria to stratify the patient's risk. And this is risk of progressive kidney disease, it's risk of developing end-stage kidney failure, it's risk of a cardiovascular event, and so on. Now, just going back to chronic kidney disease overall, the grid I've just shown you gives you a staging, but it doesn't give you the diagnosis. We still need to look for the underlying diagnosis, the cause of chronic kidney disease. And in the patients we're talking about today, that causes diabetic nephropathy, so diabetes. But of course, let's remember that there are other important causes of chronic kidney disease: hypertensive and ischemic nephropathy, glomerulonephritis, GN, and other causes. But now in the world, diabetes accounts for around about 52% of cases of chronic kidney disease and is the single most important cause of chronic kidney disease worldwide. You might want to do a few tests to exclude other diagnoses. We often do a kidney ultrasound scan. You can see an image at the bottom here from a kidney ultrasound scan showing a healthy kidney. We all want to exclude obstructiveness on the ultrasound scan. You may want to exclude prostatic disease with a prostatic specific antigen. And we also exclude immunologically mediated causes of kidney disease and virally driven causes of chronic kidney disease. And finally, we exclude myeloma. So we would want to get a protein electrophoresis and serum light chains, a viral screen, and various autoantibodies. And if we're unsure of the diagnosis, having done all of those tests, and the kidneys look normal or normal size on ultrasound, we'll probably do a kidney biopsy. Let me just stress, the vast majority of patients do not need a kidney biopsy, and in our practice do not get a kidney biopsy. And very often, the cause of chronic kidney disease is very obvious. So let's go to our first patient. He's a 68-year-old man. He's had his type 2 diabetes for 10 years. He's overweight. He's got early diabetic retinopathy, which tells me he's already got microvascular disease. He's got changes in his eyes. It's likely he also has microvascular disease in his kidneys. He's on metformin 500 milligrams twice a day, gliclazide 40 milligrams twice a day, a sulfonylurea, and a statin, atorvastatin, to minimize his cardiovascular risk. He comes up for an annual review. When he comes up for his annual review, he gets his blood pressure checked, which is a little bit high, has a blood test and a urine test. And that's standard practice in the UK, is to conduct an annual review on patients with diabetes with a blood pressure, a blood test, and a urine test. His estimated GFR is normal, 78 mils per minute, so it's above 60, which you'll remember was the threshold for CKD in patients without albuminuria. Previously 80, so it's dropped a little bit, but EGFR does drop with aging over 55 years. But he's got albumin in his urine. You'll remember the normal range using our units was 3 milligram per millimole. His UACR is 76 milligram per millimole, and a year ago it was 35 milligram per millimole. So even though his EGFR is over 60, he's got two estimates of albuminuria greater than 3, so above the normal range, so we can make a diagnosis of chronic kidney disease. His diabetes is not particularly well controlled. His HbA1c is 72 millimole per mole, or 8.7% if you use percentage. And so this man is likely to have diabetic kidney disease. Now, if you plot him on our chart here, he has stage G2A3, that's the EGFR between 60 and 90, and the albuminuria greater than 30 milligram per millimole. So if you look here, he is actually in a moderately high risk group, and we do need to focus on this man's management. So I would argue that this man is at the beginning of a journey through chronic kidney disease. I'd argue that he's on the left-hand side here in this journey. He's got newly diagnosed chronic kidney disease. We've picked it up early. We've picked it up on the basis of the albuminuria because we're screening him for albuminuria. And what we want to do is, first of all, make sure we're happy with the diagnosis. And secondly, to prevent this man progressing through the other stages, the more advanced stages of chronic kidney disease to end-stage kidney disease and ending up on dialysis like the first patient I showed you in the talk. So we want to, first of all, think what's the cause. He's had his diabetes for many years. He's got diabetic retinopathy. I think we can probably assume this is diabetic nephropathy. The albuminuria is fairly typical. And we tend to use this definition, chronic kidney disease, in a patient with diabetes in whom the kidney disease is attributable to the diabetes. That's diabetic kidney disease. As I said earlier, we don't always need a kidney biopsy. The clues are the long exposure to diabetes, the presence of retinopathy. And if you look on the left here, you can see a retinal photograph of a patient with early diabetic retinopathy with soft exudates on the retina here. And I would argue that this is like albuminuria in the eye. This is the leakage of albumin through small blood vessels into the retina, it's very likely that this same disease is going on in the kidney. And albuminuria, an increased level of albumin excretion, is typical of the early stages of diabetic kidney disease. So I don't think this man needs a biopsy. If we did perform a biopsy, we might see the type of disease we see in the histological image here, with this glomerular appearance that is described as a nodular glomerulopathy. You can see here nodules of pink staining material in this glomerulus replacing the normal blood vessels in the glomerulus. So this is a nodular glomerulopathy typical of diabetic kidney disease. As I say, most patients do not need the biopsy to make the diagnosis. So let's talk about his management. And Waziel mentioned guidelines at the beginning. This is the KDIGO, Kidney Disease Improving Global Outcomes Guideline for the management of patients with diabetes and chronic kidney disease. Now KDIGO is a not-for-profit organization. It's incorporated in Belgium. Its mission is to improve outcomes for patients with kidney disease. And it's the main way in which it does that is by producing clinical practice guidelines for clinicians around the world. And in this guideline that was published 2 years ago now, there was what I think many people find a useful pyramid of care for patients with the combination of diabetes and chronic kidney disease. So at the bottom of the pyramid, you've got some lifestyle measures that you would want to initiate in all patients. On the middle stage of the pyramid, you have some drugs that you might want to offer to most patients. And on the top of the pyramid, you have some drugs that you might want to offer to selected patients. So you'll be familiar, I'm sure, with the lifestyle changes. We want to improve glycemic control. We want to control blood pressure. We want to improve plasma lipids. We put all of these patients on a statin regardless of their cholesterol. You want to promote exercise in an effort to help the patient lose weight. You want to avoid added salt in the diet, and you want to stop the patient smoking if they smoke. So these are the lifestyle changes. The medications that KDIGO recommends for most patients are firstly RAS blockers, and secondly SGLT2 inhibitors, and we'll come on to those in just a bit. So why RAS blockade? Because RAS blockers have been proven to slow deterioration of kidney function in patients with diabetic kidney disease. And I'm taking you back now 20 years to 2 trials published in the New England Journal of Medicine in the same edition, presenting data from 2 trials of angiotensin receptor blockers in patients with diabetic kidney disease. On the left, this is the Referral trial. This randomized patients with diabetes and chronic kidney disease to losartan or placebo. On the right, the IDNT study randomized patients to irbesartan or placebo, and had a third arm, an amlodipine arm in this study. You're looking here at the proportion of patients developing events during the study, and this event is end-stage kidney disease, and you're looking at time on the x-axis here. So you'll see that in both of these trials, patients randomized to irbesartan or losartan, to the angiotensin receptor blocker, were less likely to reach end-stage kidney disease than those randomized to the placebo. And in the IDNT study on the right-hand side, those randomized to the irbesartan were less likely to reach end-stage kidney disease compared with those on amlodipine, even though the blood pressures in those 2 groups were virtually identical. So the message is there's something very special about angiotensin receptor blockers that help protect the kidney in patients with type 2 diabetes and signs of chronic kidney disease. And as a result of these trials, ACEs and ARBs became standard of care. There have been some head-to-head studies comparing ACEs with ARBs, and there's really been no differences. So whatever's easiest, whatever's cheapest, whatever's most readily available, get your patient with diabetic kidney disease onto an ACE or ARB as part of their antihypertensive regime. So we use Ramipril here in North London. It's the cheapest of the ACEs. We start in a dose of 2.5 and we up titrate to 10 milligrams. So we up titrate to get the maximum benefit from the drug. You'll remember this patient also had a high HbA1c, and that also needs attention. We need to improve diabetic control as well as improving blood pressure control. And that's where we might be thinking about an SGLT2 inhibitor. This is really a task we share with our diabetologists, our diabetic colleagues. We often have discussions about these patients to optimize their diabetic regime. But this patient would have actually got into this trial based on the inclusion and exclusion criteria. This is a trial called Credence. It's a trial of canagliflozin compared to placebo in patients who had the combination of type 2 diabetes and chronic kidney disease. A little bit like the renal and IDNT studies, but this one was conducted 20 years later and was assessing the benefit of canagliflozin on top of ACEs or ARBs. So patients needed to have an EGFR between 30 and 90. They needed to have albuminuria to get into this study, and they needed to be on the maximum tolerated dose of ACE or ARB for reasons I've just explained. Patients were randomized to canagliflozin 100 milligrams or placebo. They were followed up over time for outcome events. And this trial demonstrated a 30% reduction in the risk of this composite outcome of end-stage kidney disease, doubling of serum creatinine, or renal or cardiovascular death, death due to kidney failure or death due to a cardiovascular event. There was a 30% reduction in this endpoint, in the chances of this endpoint happening in those patients who were randomized to canagliflozin 100 milligrams compared to placebo. You'll see the numbers of participants with events, 245. Participants in the canagliflozin group have one of these events compared to 340 participants in the placebo group. So on top of ACEs and ARBs, canagliflozin 100 milligrams reduced the likelihood of this composite kidney and cardiovascular outcome. Now, the primary endpoint of this trial is at the top here. There were some secondary endpoints, including cardiovascular events, and important to point out that this drug not only prevented the kidney endpoints, but also reduced the risk of some cardiovascular endpoints. So the secondary endpoint, the secondary endpoint number 2 is cardiovascular death or hospitalization for heart failure, reduced significantly in those patients randomized to canagliflozin as compared to placebo. And there was also a reduction in the classical MACE outcome of cardiovascular death, myocardial infarction, or stroke. Again, 20% reduction favoring the canagliflozin group. Here is a drug that on top of ACEs and ARBs slows progression of diabetic kidney disease, reduces the risk of heart failure hospitalization if you've got diabetic kidney disease, and reduces the risk of MACE events in patients with type 2 diabetes and chronic kidney disease. That's all good news for patients. So that's why SGLT2 inhibitors are now in the KDIGO pyramid alongside RAS blockade as a therapy that you would offer for most patients with diabetes and chronic kidney disease. So we'll add in our patient canagliflozin 100 milligrams once daily. That will, of course, help to improve the management of diabetes. His HbA1c will come down, but importantly, this will provide added kidney and cardiovascular protection. And I hope you've got these drugs available in your region, or will have them available soon. Now, when we start canagliflozin, we may see a small drop in EGFR. We will certainly see a drop in albuminuria, and we are likely to see a drop in HbA1c. Let me just talk about the drop in EGFR. This is the same as we see with ACEs and ARBs. These drugs are thought to reduce the pressure within the glomeruli, and by doing that, they lead initially to a small reduction in EGFR that in the long term translates into kidney protection. If you do see a small reduction in EGFR when you start these drugs, don't worry, keep the patient on the drug, continue to follow the patient up. This is expected when we start these drugs. It shows that the drug is doing what it should do. It's reducing intraglomerular pressure. This is my second patient, and I use this patient to demonstrate some other points about managing diabetic kidney disease. He's also male, he's 64-year-old, Asian male. He's also overweight. He's had his diabetes for 16 years. He's had laser treatment for his retinopathy, and his blood pressure again is too high. So similar to our first patient. His HbA1c is really very poorly controlled at 88 millimole per mole or 10.2%. And his GFR is 35 mil per minute. A year ago, it was 41 mil per minute. This man's kidney function is declining quickly. He has albuminuria, 42 milligram per millimole, so he's in the A3 range. His hemoglobin is starting to fall, 10.8 grams per deciliter or 108 grams per liter. He's on metformin, gliclazide, atorvastatin, and he's on ramipril, 10 milligrams once a day. So he's already got kidney protection in the form of ramipril. He's not on an SGLT2 inhibitor. So let's stage him. He's got B3BA3 chronic kidney disease. He's in a red square. He's at very high risk of progression to end-stage kidney disease and of cardiovascular complications. And what we actually do in the UK now is we use this kidney failure risk equation. This is an online tool. The website address is at the bottom here. You can download this on your phone. And by putting in the patient's gender, age, EGFR, and level of albuminuria, you can get a prediction of the likelihood that they will be on dialysis in 2 years and in 5 years. And this man has a 5-year risk of being on dialysis of 15.5%. So there's a good chance he's going to run into trouble. Let's look at our patient journey again. This patient's sort of in this middle zone where he's progressing through the stages of chronic kidney disease, and we're asking, can we control this progression? Are we controlling his blood pressure? Is he on an ACE or ARB? Is he on an SGLT2 inhibitor? Are we doing everything we can to control this man's progression? Because the next stage here is that he's ready to work up for dialysis. And we tend to see patients in our clinic when the EGFR drops below 30 if they're diabetic, so that we can prepare them for end-stage kidney disease and start getting them ready for dialysis or kidney transplantation if appropriate. So this man's in this middle stage of his journey. We hope we can stop him getting to end-stage kidney disease. We need to do everything we can to slow down the deterioration in his kidney function. And also, if you look at the bottom here, watch out for the complications of chronic kidney disease that start to develop at this stage. And this patient's already becoming anemic. Now, he would have got into this trial. In fact, both of the patients I've described would have got into this trial. This is another trial of SGLT2 inhibitors in patients with chronic kidney disease. This is a trial of dapagliflozin. The GFR range is a little bit lower here, 25 to 75 for inclusion. Patients needed albuminuria. Patients needed to be on the maximum tolerated dose of ACE or ARB if possible. And importantly here, we recruited patients not only with diabetes, but we recruited patients who had chronic kidney disease who did not have type 2 diabetes. Remembering this is a trial of a diabetes drug. Now, we excluded type 1 diabetics and we excluded patients with immunologically active systemic or kidney disease. In this trial, the DAPA-CKD trial, the randomization was to dapagliflozin 10 milligrams or placebo. This was, again, an endpoint-driven study. The primary outcome was very similar to the Credence study, except instead of a doubling of serum creatinine, we used a greater than or equal to 50% decline in EGFR. A doubling of serum creatinine is a 57% EGFR decline, so this is a little bit more sensitive. end-stage kidney disease or renal or cardiovascular death. The result looks very similar to Credence. Here you can see a hazard ratio of 0.61. So that's a 39% reduction in the risk of this composite outcome, favoring the dapagliflozin arm of the trial over the placebo arm. And again, we saw a broad spectrum of benefits. These are our secondary outcomes. The left graph is the primary outcome without cardiovascular death. So this is just kidney events. The middle graph is cardiovascular death or heart failure hospitalization. Again, a statistically significant reduction in this endpoint favoring dapagliflozin. And finally, on the right-hand side here, we've got all-cause mortality. This drug reduced all-cause mortality in this trial, in this patient population. So here's, to my knowledge, the first drug we have that reduces mortality in patients with kidney disease with and without type 2 diabetes. Now, crucially, did it matter if the patient had type 2 diabetes or not going into this trial? And the answer is no. Here's the primary outcome for patients who had diabetes going into the trial on the left, who did not have diabetes going into the trial on the right. The results are very, very similar in the two groups. So here we've taken a diabetes drug, we've trialed it in patients with chronic kidney disease with diabetes and it works. And we've also trialed it in patients with chronic kidney disease who do not have type 2 diabetes, and it also works. So we need to understand the mechanisms of action. This is a diabetic talk. I'm not going to talk anymore about the non-diabetics, but dapagliflozin is a drug for patients with chronic kidney disease with and without type 2 diabetes. So let's go back to our patient. We're going to add in dapagliflozin 10 milligrams. We need some help from our diabetic colleagues. We may need some injectables here, GLP-1 receptor agonists or insulin therapies to control his diabetes, even after adding dapagliflozin. So this man may well progress, and as he progresses, we want to think about how we're going to manage his end-stage kidney disease. And I said earlier that we would see diabetics once their EGFR dropped below 30 ml per minute. We would want to talk to them about their wishes, about what type of renal replacement therapy they want. If they want any renal replacement therapy at all, we would assess their suitability for transplantation. And if they're not suitable for either dialysis or transplantation, we have a conservative care package that manages their complications, manages them medically without dialysis, and provides end-of-life care if that's required. In terms of the complications that these patients start to develop, I put a list on the right-hand side here. We've mentioned anemia, metabolic bone disease, metabolic acidosis that exacerbates hyperkalemia, cardiovascular and peripheral vascular disease, an increased risk of infections, acute kidney injury, and premature death. And so once we're getting to sort of stage 4 CKD, we're managing all these complications. My own view is that these patients should be in nephrology clinics if at all possible. So just a couple of words about managing diabetes in the context of stage 4 to stage 5 chronic kidney disease, because as chronic kidney disease advances, it gets harder to manage diabetes. And that's because we can't use all the drugs or the drugs become less safe. So we tend to stop metformin when EGFR drops below 30. That's a safety issue. There's an increased risk of lactic acidosis in patients who are on metformin with an EGFR of less than 30 mL per minute. You can still use the thiazolidinediones if you like those, the pioglitazones. Remember that they can cause fluid retention. You can use the sulfonylureas like gliclazide or tolbutamide, but remember these drugs accumulate and they accumulate more in patients with lower levels of kidney function. So watch out for declining levels of HbA1c and hypoglycemia. You can use the DPP4s with some of them with no dose adjustment. I've got linagliptin here. You can use the GLP-1 receptor agonists. Again, semaglutide does not require dose adjustments. You may need to change insulin doses as GFR declines And as I said, SGLT2s have become an attractive therapy for these patients. Certainly in our country, we can use dapagliflozin down to an EGFR of 15 mils per minute. So right down to stage 5 chronic kidney disease. Just before I finish, I want to say a little bit about managing these patients. These patients are complex. They have diabetes, they have chronic kidney disease. They often have other comorbidities like heart failure, coronary artery disease. They may have respiratory disease. And we feel that the best way to manage these patients is collaboratively establishing strong links between primary and secondary care, having easy access to hospital clinics, but also letting the GP, the primary care physician, manage and monitor the patients. And the way we do this in North London is that we share a database. We have one database that the primary care physicians, the GPs, use, and secondary care nephrologists have access to this database. So when a GP is worried about a patient, they can refer them to us virtually without us needing to see the patient. We can log on to the electronic record. We can see the patient, we can see all the results, and we can provide advice on the management of that patient. And we can also work out whether we feel we need to see that patient in a secondary care clinic. We have criteria for referral, although we say to GPs, if you're worried about a patient, please refer them. We say the same to our diabetic colleagues. If you're worried about a patient, just let us know and we'll have a look at them. We'll have a look at their records and see if we feel we can do anything to help. But we do have some criteria for referral using that risk equation that I showed you earlier, the risk calculator. We like to see patients who have a 5-year risk of end-stage kidney disease that's greater than 5%, so we can prepare those patients. We like to see patients who have large amounts of albumin in their urine because they're going to progress more quickly. We like to see patients whose EGFR drops and drops fast. We would want to see all patients who reach an EGFR of greater than 30 mils per minute. We'll see patients with hypertension that's difficult to control. We'll see patients with genetic or rare diseases that who need help and advice. And we'll see patients with suspected renal artery stenosis and any other patients that you're worried about. And this is local guidance from NICE, which is the organization that helps provide guidelines specific to the UK. So I'm going to finish. This is the framework for managing a patient with diabetes and chronic kidney disease. What's the EGFR and what's the UACR? So what stage are they at? Do we know the cause? Do we need a diagnostic biopsy? Do we need other tests to get to the cause? Or are we happy that it's diabetic kidney disease? Once we're happy, is the blood pressure under control? Is the diabetes under control? If albuminuria is present, is the patient on an ACE or ARBs? Are the medications appropriate? So as EGFR declines, we need to keep doing a check to check the patients are on appropriate medicines. We put all of these patients on a statin. And then if the patient's likely to require renal replacement therapy and reach end stage, we want to get these patients into the right clinic, into a nephrology clinic, or we need to line them up for appropriate end-of-life care if we're not going to offer them dialysis or kidney transplantation. So here's a few, just to finish, take-home messages. Albuminuria may be the earliest sign of diabetic kidney disease. Look out for it. We do annual reviews of our diabetic patients to try and pick up kidney disease early. Early intervention slows progression, and the earlier we intervene, the greater chance we have of delaying the end-stage kidney disease and getting the patient through their life with kidney function, not needing dialysis during their lifetime. Managing chronic kidney disease involves lots of different teams. We need good communication. We need clear referral criteria. We can often avoid patients starting dialysis, renal replacement therapy, but those who do start need to be properly prepared. And we know that patients who start dialysis properly prepared for dialysis have better outcomes on dialysis than those who don't. So even though I would look upon starting dialysis as a little bit of a failure of the patient management, patients who do start dialysis who are prepared do better once they're on dialysis and we believe live longer. Waziel, thank you very much for listening to me. I hope that was helpful.
Thank you, David, for that excellent presentation. And we have some questions lined up. Let me ask the first question. As a nephrologist, when would you like to see the patient with diabetic kidney disease?
At any time that the diabetologist or the primary care physician is worried about them. So that could be right at the beginning when they're first diagnosed. If there's doubt about the diagnosis, let's say there's blood in the urine, let's say that there are some other tests that are not normal, let's say the patient has lower urinary tract symptoms. If there's any concerns about the diagnosis, we would want to see that patient, you know, as early as you like. We'd also like to see patients who are definitely progressing and who are progressing quickly. If you've got everything in place, you've got the ACEs and ARBs in place, the SGLT2 in place, they're still progressing. Let's just have a look at them and check we're not missing something. And then finally, we need to prepare patients for dialysis. So I would argue we need to see all patients when their EGFR drops below 30 or 25, 30 for diabetics, 25 for non-diabetics. We want to get them ready for dialysis or end-of-life treatment, or talk to them, just talk to them about what will happen when their kidneys fail and see what their wishes are. So I can't give you a particular cutoff for EGFR, but I think we'll see patients at any stage if there's concerns about it.
Thank you. And there are some questions from the audience. Dr. Rajita Vanasuri is asking, we are using Empagliflozin as a drug to control blood sugar. Can't we use more cheaper, widely available drugs like metformin or sulfonylurea? Or is there some added benefit by using SGLT2 inhibitor in diabetic kidney disease?
No, I'm glad to hear that you have access to Empagliflozin. There are added benefits. The Credence trial and the DAPA-CKD trial showed very clearly that in patients with type 2 diabetes who are already on standard medicines, including ACEs and ARBs, who have reasonably good diabetic control, I didn't show those data, gain added benefit when on an SGLT2 inhibitor. They gain benefit in terms of slowing progression of kidney disease. They gain benefit in terms of reducing cardiovascular events. So these patients need to be on an SGLT2 as well. Now, I should also add that once EGFR drops below 45, SGLT2 inhibitors don't tend to lower blood sugar. So we're no longer looking at them as agents to control blood sugar. We're looking at them as agents to protect kidneys and protect hearts. We're using them for something slightly different. And certainly in the non-diabetic kidney disease patients, we're putting our patients on SGLT2s, EGFRs of around 45 or so. We're not seeing any changes in blood sugars. They're not diabetic patients. The SGLT2 inhibitors don't do anything to blood sugars below an EGFR 45, but we are seeing the kidney protective benefits of these drugs in that patient population. So if the patient's diabetic, add in an SGLT2 inhibitor as part of the diabetic regime, but you're really using that drug for kidney protection and cardiovascular protection. DPP4 inhibitors do not do this. Metformin probably doesn't do this to the same extent. Sulfonylureas do not do this. And we're still learning whether or not GLP-1 receptor agonists do this. But they don't seem to do it in such a spectacular way as the SGLT2 inhibitors do.
Thank you, David. There is another question. What is the role of diltiazem in controlling proteinuria in patients with diabetes?
So I think, you know, if a patient's hypertensive, any blood pressure lowering drug will help them. Diltiazem, calcium channel blocker, we use quite a lot. It's beneficial. There are some studies showing a superiority over other blood pressure lowering agents. They're not big studies. They haven't looked at kidney failure endpoints, but there are studies of diltiazem in diabetic kidney patients. And I think you need many drugs to control blood pressure. So you use diltiazem, of course, as one of those drugs, or amlodipine or nifedipine, but don't use that instead of an SGLT2 inhibitor and an angiotensin receptor blocker. Use it in addition. Use it. You're going to need more than one drug to control blood pressure in many of these patients, and a calcium channel blocker, either a dihydropyridine or non-dihydropyridine, is a very good choice on top of an ACE and ARB to control blood pressure.
Thank you, David. There's another question. What is the place of RAS blockers in patients with diabetic with albuminuria without hypertension?
Yeah, that's a great question. I think there's some debate about this. The trials did include some patients who didn't have particularly high blood pressures. The view in the nephrology world is that there is a benefit from reducing the albuminuria, even when the blood pressure is normal. I don't think there's a strong evidence base for that, but most nephrologists will add in the ACE or ARBs, even when blood pressures are reasonably well controlled, in an order to provide kidney protection. As I say, there's not a good evidence base behind that, but that's what we tend to do. And as I say, in the NARL trial and the IDNT trial, there were many patients who didn't have particular high blood pressures. The patients in those trials were not selected for having hypertension. So I believe there's benefits to ACE/ARBs over and above their ability to lower blood pressure, and we should get all our patients onto these drugs, all our patients who have albuminuria onto these drugs. The evidence for non-albuminuric patients is not strong, and I wouldn't have same desire to get all of my non-albuminuric patients onto ACEs and ARBs. The data is not so good.
Thank you, David. There's a question from Kanishka Disanayaka. What about Empagliflozin? What is the EGFR that we should be told Empagliflozin? Empagliflozin is very freely available in Sri Lanka.
Yeah, so there's a trial called Empogliflozin, which is the third trial in the series of diabetic kidney disease trials, or I should say chronic kidney disease trials of the SGLT2s. We had Credence, we had Dapagliflozin, we've got Empogliflozin, and we've learned that Empogliflozin has just been stopped by the Data Safety Monitoring Committee because of the overwhelming efficacy of the drug. So it looks like we're going to see a positive result from the Empogliflozin study. The Empogliflozin study recruited a broad range of patients with chronic kidney disease, with EGFRs right down to 20. It recruited patients with diabetes and without diabetes, and it recruited patients who had non-albuminuria or DAPA-CKD. So we're going to have the Empogliflozin trial results, we believe, sometime this year. I wouldn't like to predict what they're going to show, but we do know that the drug was effective and the trial was stopped on the basis of that overwhelming efficacy. So I think this is a... Dr. Waziel, I lost you there, but I'm back now.
Yeah, right, okay. Thank you, David. There's another question from Mathu Selvaraja. What is the place of Eplernon in diabetic kidney disease with persistent proteinuria while on ARB and SGLT2 blocker?
So great question. So we're aware of a trial or two trials, one called Fidelio, one called Figaro, that have used a third generation mineralocorticoid receptor antagonist, a non-steroidal MRA, in patients with diabetic kidney disease, and showed cardiovascular and kidney benefits. These trials were published about a year or so ago now. So if we've got patients with diabetic kidney disease who were on ACEs and ARBs, adding in finerenone was a benefit. Now, most of those patients were not on an SGLT2, so we're not completely sure that adding the finerenone onto the SGLT2 is going to have added benefits. There's a small subgroup analysis of the study that suggests that it probably will. Now, that's finerenone, but the question was about Eplernon, which was the second generation of mineralocorticoid receptor antagonists. They're widely available. They have a slightly different structure to the third generations, but you know, if they're available, they may be a good option. So to answer the question, I believe that on top of ACEs and ARBs, mineralocorticoid receptor antagonists have added cardiovascular and renal benefit in diabetic kidney disease. If I'd had time, I would have talked about that. But we have to remember that we haven't got good trials of the combination of ACE inhibitors and SGLT2 inhibitors and MRAs. We don't have trials of the three agents just yet. But you know, if you've got MRAs available and you can use them safely without creating hyperkalemia, then these are very attractive drugs for patients with diabetic kidney disease. So thank you for that question. What I don't know is whether eplerenone, finerenone, and spironolactone, the first generation, are all going to have similar benefits. But this is certainly the direction we're heading in the management of diabetic kidney disease.
Thank you, David. There's a last question. How does empagliflozin compare to dapagliflozin for patients with diabetic kidney disease? Are there any head-to-head comparison?
No, I mean, there's no heads-to-heads. If you look at the mandated safety studies, so if you look at the EMPA reg study, the DECLARE study, and the CANVAS study, the studies that the regulators demanded were done in diabetic patients, and you look at the kidney signals in those trials, there's a remarkable similarity between the kidney benefits. Now, those are patients who by and large didn't have kidney disease. This is the early development of albuminuria and early GFR changes, but the indications from those studies is that these drugs are equivalent, certainly in patients with early diabetic kidney disease. And I don't think there's a lot to distinguish between them. Ertugliflozin, which was the fourth one to go through trials, the data weren't quite so clear. But I think you've got EMPA or DAPA, you've got a good drug for diabetic kidney disease, in my view.
Thank you, David. We are almost come to the end of our lecture, and I will hand over to Dr. Niroshan to wind up the session.
As a concluding remark, again, I must say, Prof. David Wheeler, we are honored with your presence in this forum. Thank you for your elaborative lecture. Special thanks should go to Dr. Waziel for organizing and moderating this session. Thank you, sir. And on behalf of Ceylon College of Physicians, my heartfelt gratitude goes to Sri Lanka Society of Nephrology, especially support from President Dr. Mathu Selvaraja, to secretaries Dr. Darshi Anuruddhika and Dr. Udana Ratnapala, and also Dr. Dilushi Vijayaratna. Finally, I would like to thank all of the online participants, despite who attends here, despite their busy schedule. Then shall we conclude the sessions? Thank you, everybody. Good night.
Good night.
Thank you very much.